Hello, my name is Beverly. I'm the nurse practitioner, and I will be doing a musculoskeletal exam. Hi.
Hi,
What's your name?
Shauna,
And your date of birth?
5/18/68.
And before I start my exam, I'll go ahead and wash my hands. The first thing I'm gonna do is I'm gonna inspect her hands. You wanna inspect the hands, you wanna observe for any deformities, any redness, any swelling, observe the joints, you wanna look at her fingers and her wrist, you wanna palpate the distal and proximal joint for any tenderness, any lumps that would be indicative of osteoarthritis or rheumatoid arthritis. And I would go ahead and palpate the ulnar and the radial heads for any tenderness and any warmth or any swelling. After we palpate, we'll go ahead and do some range of motion, which is extension and flexion. I'll have the patient do flexion and then extension. And then we'll do the fingers, which is abduction away, and adduction, which is towards the body. So this is abduction, where she opens her fingers. Adduction, she closes her fingers. And then we're gonna go ahead and do the wrist. We're gonna do abduction, abduction, and then adduction, and then we're gonna do flexion and extension. And then we can also do an Allen's test just to see if she has any carpal tunnel test, which I would include the ulnar and the radial arteries. She would open her hands, she would close her hands. I would include both arteries. I would have her open her hands. The hands are pale. I would uninclude one of the arteries and you would see the color come back. And actually you do it again on the other side and occlude the other artery while doing the same test again. Then we'll go on to the elbows, and we're gonna go ahead and inspect the elbows, make sure there's no deformity, no redness, no swelling, no discoloration, no masses, no nodules, that's noted. I am gonna go ahead and palpate the tip of her elbow, which is the olecranon process, all the way to the medial and lateral epicondyle. And during my palpation here, if the patient says she has any pain, this can be an indicative of golfer syndrome. Do you have any pain there?
No.
No. Then we're going to go ahead and do the range of motion of the elbow, which is flexion and extension, pronation, and supination. And that's it for the elbow. And then we're going to go ahead, and I'm going to go ahead and do the shoulder as part of the musculoskeletal, which it is part of the musculoskeletal. And I'm going to go ahead and inspect for the shoulder, make sure it's symmetrical, there's no deformities, there's no redness, there's no swelling. And of course, you would do it on both sides, but for the sake of the video, I'm only going to inspect, palpate, and do range of motion on one shoulder. And of course, the patient would be in a gown, she wouldn't be dressed, and I could see better. So the first thing I'm going to do is palpate. I'm going to start with the suprasternal notch, and I'm going to walk my finger along the clavicle to the acromion process, which is the bone that's on top of the shoulder, to the little ridge, which you can feel medial from here, is a little ridge where the AC joint is. And then I'm going to bring my hands down and then look for the deltoid pectoral groove, feeling for the corticoid process to the lesser and to the greater tubercle process. Then I'm going to palpate the bicipital groove. Then I'm going to do range of motion, of course, and I'm going to look for the symmetry again of the shoulders, making sure one shoulder is not lower than the other one, which can be indicative of a dislocation of a shoulder. We're going to do range of motion. We're going to compare again. We're going to have her stand up. We're going to do forward flexion, okay, and then extension, which is through the back. There you go. And then abduction, which is away, and then abduction, which is she's crossing her elbows across her body or her arms. And this is also a test that's called the crossed arm test. And at that time, if the patient crosses with her arms, when she crosses her arms over her body and she says there's pain, this can be indicative of a rotator cuff injury. And then we'll do the internal and external rotation, which the patient will scratch her neck, the back of her neck with her arms. And then I'll have her, that's internal. And then external is she scratches the opposite scapula of her arm. Right? And then I'm going to have her, what am I doing? I'm going to have her turn around and I'm going to palpate her spine. Of course, the spine, no, this is the shoulder, I'm sorry. That's a rotator cuff, that's the shoulder, muscular to skeletal shoulder. Then I'm going to do the spine, which begins with the neck. So I'm going to go ahead and inspect her neck, anterior and posterior, making sure that the trachea is midline. And then we can do range of motion of the neck, which is the chin to chest, which is the flexion. She's going to look up at the ceiling, back, and that's extension. Then she can do the cervical rotation, which she looks left and she looks right, and the lateral bend, which is her ear touching her shoulders on both sides. Then I'm going to go have her turn around. We're going to go ahead and palpate starting from the C7 all the way down, walking the fingers down, feeling for any tenderness or any vertebrae depression or any vertebrae protruding, which is sticking out, which can be, which is called the step off side. And then from here, I'll palpate the muscles, which is the paravertebral muscles, checking for any fine. This is on the sides of the spine's in the middle, for any rigidity or any pain and any spasms. And then we'll go ahead and do the range of motion, which is, I'm going to have her bend forward. At this time, I'm checking the alignment of her spine to make sure she doesn't have any scoliosis. And then from here, I can check her hips to make sure it's even. One is not higher than the other. Limp lip test is the test to see if it's lower or higher, and to see if her one leg is shorter than the other. Then we're going to go have her do an extension, which she'll stand, she'll bend backwards, then she'll twist for me. Twist on both sides, making sure she has no pain. Do you have any pain?
Nope.
Okay, and lateral bending on both sides. Now we're going to do the hips. We're going to have her sit down, and then we're going to inspect and have her lay back. Usually the patient would be undressed if they were complaining of any hip pain. We're going to of course inspect again for any deformities, any redness, any bruising, any discoloration. I'm going to check and palpate for any tenderness of the hips. And then we'll do the range of motion, which is extension. And then with the flexion, of course you do it both sides. We'll have her lay on her belly. And then we'll have her raise her leg up. Okay, then we'll have her do her sides, because there's also the external and internal rotation, which is side to side. So the internal, which is internal, we'll have her go this way, and then we'll go that way, which this would be away from the body, so this is adduction. Okay, and then from the hip, I would also, that's the range of motion, which I should have done after. I'm going to go ahead and palpate the hip for the anterior superior iliac spine to the greater trochanter, which is right here, to the ischial tuberosity, which is the butt bone right here. And in between there is the sciatic notch, and the sciatic notch is the sciatic nerve. And you want to just palpate lightly here, because the patient may have sciatica or other nerve pain here. And then from here, you can look at the SI joints, which in surfers, you can usually see it. It's in the base of the spine, above the buttocks, and you'll see some dimpling here. The next one we're gonna do is we're gonna do the knees. We're gonna inspect the knees for any symmetry, of course, on both, any swelling, bruising, anything protruding, any discoloration, any swelling, anything bulging out. I'm gonna palpate the knees, and I'm gonna palpate the medial surface of the knees. Of course, you would do it on both sides. And then I would look for the patellar, the groove, and the tibial tuberosity. And then you got the medial and the lateral grooves on the sides. You would do it here. And in between there, there's the meniscus. This is by feeling on the medial and the lateral side of the knees, you would be able to, the meniscal groove. And then if there's any pain, it would be considered a meniscal tear. Okay? And then we would do the back of the knees, and I'll have the, well, I could just do here. So in the back of the knees, you would palpate and inspect the knees. And if you feel a ball, that can be indicative of a Baker's cyst. For the knees, we do, again, flexion, extension, and we do abduction and adduction, okay? So flexion, and then I would have her stand up. Go ahead and stand up. So for the flexion, we would do that way, and then flexion, adduction, and then we would do, I'm going to have them side to side, yeah. So we could do adduction and, no, adduction, abduction, and adduction, okay? Then we would move down to the foot. I would, of course, she doesn't want to take her socks off, so we'll just pretend that she has no socks on. And then we would inspect for any redness, any swelling, any bruising. And we would look at her great big toe, especially in the NTP joint, to make sure she doesn't have any gout. Usually if they have pain here, any swelling on the great big toe, that can be indicative of gout. That's where usually it starts. We would palpate the lateral malleolus and the medial malleolus, which is the bone here. Let me see. You pretend there's a big bone here, and then the bone here. You would feel for that. Make sure if there's any pain. You would look. You would feel for the calcaneus, which is the heel bone. Feel the metacarpals all the way to the DIP and PIP joint. You would look at the arch of the foot to make sure she has an arch, because if she was flat-footed, this can she can have like hip pain, knee pain, back pain. Range of motion for the feet is flexion and extension. So flexion, extension, and we have, then you would kind of manipulate inversion and eversion. Or you could just have the patient do circles. Can you make circles around your ankles? So that's another way if you forget to do the inversion and eversion. And that's the end of my musculoskeletal exam. Thank you.